I'm here with Dr. Earl Dunn, Lifetime Achievement Award winner at the College of Family Physicians, and a lifetime family medicine doctor. Spent 5 years working in rural practice in the Laurentians in Quebec, and the remainder of your career has been at Sunnybrook in Toronto. Also a professor at the University of Toronto, and post-retirement spent 8 years in family medicine in the Middle East, United Arab Emirates. So welcome, Dr. Dunn.
Thank you.
I know that you were originally, your first career was in engineering. Then
Correct.
You moved to family medicine.
Yes.
How did that happen?
I always wanted to do medicine, but I didn't have any money. So I needed to earn some money to go to medical school. My parents didn't have a lot of money. And my high school math teacher told me that if I went to university and got a math degree, I could then work for insurance companies or work as an engineer. And the first job offer I had was from Canada Air to work as a aerospace engineer. So I did that for a couple of years. But I always intended on doing medicine.
Okay.
I love the engineering.
Fair enough. Okay. So then you practiced in the Laurentians, rural medicine. I imagine it was quite a different world from what today's family medicine setting or even a rural setting is. Can you tell me a bit about the differences?
Well, I think each rural setting, each practice is unique. But in rural medicine, I think it's unique. For example, in my practice or my area, the local vet was one of the world-class judges in horse shows. And he was always gone to judge things. And so people started to come to me for the problems with their animals as well as problems with their cells and their families. So I did a little bit of veterinary medicine. Nice patients. Animals are good patients. They don't complain. And they're very pain tolerant. And so, yeah, it's different. And also, I think, compared to my practice in Toronto, you got to know people. I covered an area up the Rouge River, 20 miles by 40 miles. And everyone in that area, with one or two exceptions of people who wanted to drive 50 miles to see a doctor, they were all my patients. So I had the whole family. I had all the relatives and so forth. So you really got to know families, family interactions, and that kind of thing, much better than I did in Toronto, where it would be unusual if all of the family came to me as their physician.
And how about all the things that are done today with the technology and the knowledge of, advanced medicine, and I'm sure you had to improvise a lot.
Yeah, I did my own x-rays. I did my own lab work, growing cultures, but other than that, my own blood tests, hemoglobins. But if I wanted to do electrolytes, any kind of even what we would consider basic, simple tests, patients had to drive 30 miles to have it done. So in general, you depended much less on laboratory tests. Now, that was also, I'm talking about the 1960s, and even hospital medicine was less technically advanced and so forth as now. I think that technology is a big help, but we often forget that there's people who are behind the technology and need to be looked after, and need the technology explained to them.
So You've had some unusual patients, to say the least. Can you tell me about a couple of them?
Well, I think one of the most dramatic, when I was up in my rural practice, I had a little boy next door who wandered all through the woods and used to bring me animals that were injured, birds, whatever. And we had our little secret. He'd come and knock on the window. And then when I was ready, I'd nod and go and open the back door of my office. And he would come in with whatever it was at the end of my regular office hours. And this day he came and knocked on the window, and he had a box in his hand. And I went and opened the back door and went to develop a chest x-ray I'd taken during the office. And I came out, and he was there on my examining table, stroking a skunk on the chin and jaw, who had gotten a fight with a fox and had his stomach cut open and so forth. And my first thought was, how do I have evening office hours if this skunk decides to let go on it? I sewed up his abdomen, he went out, didn't say.
Somehow he knew.
He knew, yes. And this boy was excellent with animals. Yeah.
And I guess that was an unusual patient. What is it like to, like you said, to care for generations in a family that may not happen in a city or a large...
Well, I think it takes a lot of delicate things because there are family tensions and family feuds, if you want. And you have to be very aware of those. So if you, deal with one family member in a way that other family members may think appropriate, either you're paying too much attention to them or you're paying not enough attention to them, you get caught in the middle of the family feuds. And I personally tried after, I guess I'd been there 6 months and realized this, that I would make every endeavor I could to keep out of the family feuds and keep neutral. They would also try very hard to get me to take sides, especially in care for the elderly. I mean, this again is back in the 1960s, early 1970s, where we didn't have the current long-term care facilities, home care, and virtually every farmhouse in my area had an elderly person upstairs or had a child with disabilities and so forth. And so there was often family feuds. I remember one instance where in the middle of the winter, I was called to go and see this lady who stayed with one of her sons in a way off back road and full of snow, and I couldn't get in, so he met me at the road and we went in by skidoo, and this lady had pneumonia and was quite sick, and I gave her shot of penicillin, something, I don't remember what, said I'll come back tomorrow, but she's very sick and hopefully she's going to get through this. And went home. And then that afternoon, I got a very irate phone call from her daughter, who lived 15 miles down the road, had not visited her mother in 10 years. And I was doing very inappropriate care. She had to be in the hospital and so forth. I said, look, we can't get her out to the hospital, ambulance can't get in. And I'll go in every day and maybe twice a day to see her. So, no, we have to get her in the hospital. So she called a private ambulance. She got someone with a horse and sleigh and went in and they bundled the mother up and put her in the horse and the sleigh. And halfway out, the sleigh tipped over and they dumped her mother in a snowbank. And then they got her out into the ambulance, and she went to the hospital and died in the hospital. And for the next 5 years, she blamed me for her mother's death. And she had had very little contact with her mother, but all of a sudden, no one was treating her properly. Her son never looked after her mother properly anyway. So I tried to stay out of those things. In the city practice, it was much easier to do that because you're much less involved. But in the rural practice, you can get caught in these family feuds, family dynamics, and so forth, which make life interesting, but also you had to be more careful. Yeah.
So there's talk today about bringing back the home visits, and what advice would you have?
Oh, I think you have to do it carefully. I am a firm believer in home visits. You learn a lot by just walking in a house and seeing how clean is the kitchen or whatever. Although, especially the lady, I've had very sick ladies who spent 2 hours cleaning up the house because they knew I was going to do a house call. And so, but you see a lot of things. If it's a sick person, you're often going to the bedroom and, what and is a household set up and what are the dynamics in the house. Even little things like going up and down stairs, how safe it is. And so you learn a lot. But I think, on the other hand, in this day and age, with the number of patients that need to be seen and so forth, you can't spend all your time doing house calls. Now, I know there are physicians who spend all their time doing house calls, but that's very special circumstances. So I think you have to keep control of it and let your patients know what your expectation is and what their expectation is. But I'm still a believer in house calls and, very elderly people who just need their flu shot, need a B12 shot, and so forth. It's a lot easier for me anyway. It was a lot easier on my way home. I just drop in, spend 5 minutes talking, give them their B12 shot, and go on my way. For them to go to my office was often a half day of getting dressed, getting transportation, coming to my office, sitting for whatever, hopefully 20 minutes or less. But it's a half-day job. For me, it was 5 minutes to ring the bell, give them a flu shot or whatever it was, and go on my way. So I would often, or if I was doing another house call, that on a sick patient, I would often phone my patients, very elderly patients I was doing fairly regular calls, say, I know I'm supposed to come on Friday, but can I come today? Because I'm in the areas.
At what time did you decide to get involved in research?
Oh, I did research as an engineer. As an engineer. So, I was in the research section of Canada in Montreal here. So, I'd already got it. But when I got into practice, I wasn't bored with practice, but looking at little things in the practice made life more interesting. And I've always said, you do research because it's fun. Now, parts of it is not fun, but you do it because it's fun. And if you're not getting enjoyment, don't do it. You don't have to. And I always had fun doing my research, which is why I've done research in odd, funny things.
Odd, funny things.
Well, unusual things.
Okay, tell me about some of those.
Oh, I guess the one that we had the most ribbing about is we did snoring studies. And one time we had a ear, nose, and throat man who came into our research unit. Two of us were there, and he said, well, I had this idea about doing something about nasal functioning and so forth, and who's interested? And then as he's going out the door, he says something about, oh, and then there's snoring, and both of us said, snoring, come back here. And the literature said at that time, which had all been done by ENT people, said 7% will snort. Well, everyone I talked to had a member in their family who snored. We didn't believe it was 7%. So we did a study. We actually asked patients if their partner snored or their family member snored. We didn't ask people if they snored. When we asked people if they snored, no one snored, or 10%. And we found that 75–80% of people were reported by other people to snore. And then we looked at what diseases they had, because we'd done this in our practice. And we also did it in an industrial plant as well, but we did it in our practice so we could tie it to their disease index. And we were able to show that there was an increase in diabetes, cardiovascular disease, and so forth. So we were the first ones to report the association between snoring. We didn't look at sleep apnea. People now are more publishing about sleep apnea, but we were the first people, and we published in the British Medical Journal the first article relating snoring to major consequences like cardiovascular disease and so forth. And I was told a couple of months ago I was just sitting at a dinner, and sitting beside me happened to be a PhD student who was looking at health administration, and his remark was that he decided our paper led to the $15 billion sleep lab industry that there are today. But it was more than us. It wasn't just us. But we had the first paper, and then people started looking at the relationships and then got into the sleep labs and CPAPs and all that. So, did those kind of things. And just one of my interests was always trying to get data to show that the things we all believed in medicine were not true. When I went to medical school, if you had splinter hemorrhages, little bleeds under your fingernails, you had subacute bacterial endocarditis, and you were lucky. That was before the days of the current antibiotics. You were lucky if you survived 4 months, 6 months. Well, I used to get splinter hemorrhages, and I thought, am I dying of subacute bacterial endocarditis? I was working in my mining town, and I used to do annual physicals and all the employees. So I set up a chart system, and I started keeping track of people. So in the middle of the physical examination, I just glance at their fingers and see if they had splinter hemorrhages. And 30% of them had. All the receptionists, typists who spent time at typewriters all had splinter hemorrhages. And I decided, and I recorded on myself when I got them. And every time I cut my fingernails, I get a splinter hemorrhage. So my theory was you'd pull back the nail a little bit, and then you'd get a little bleed underneath the nail. And so that I satisfied myself and some other people. I presented a paper at NAPCRI for that, never got around to publishing it. I moved from my rural practice to the city. In the move, I lost all my data and couldn't find it again. But I didn't mind. I proved to myself that our things we believed to be universally true wasn't universally true. And so that was one of the things that I've been interested in.
You're also known as the Father of Telemedicine. Can you tell me about your how you began research behind that, or?
It was interesting the way that started. There was a professor of management sciences at that time at the University of Waterloo. He later on became Dean of Engineering at McMaster, who got the idea. He had worked with Bell Canada in telephones and whatever, and he got the idea that telephones and remote medicine, telemedicine, probably had some validity. So he started asking some friends, he needed a physician colleague. And then one person he asked says, oh, you have to go and talk to Earl Dunn. He's an engineer as well as a doctor. So he came to see me, and we started doing first, he got some of his PhD students to go into doctors' offices to, in fact, see what they did. Because if you're going to practice medicine, telemedicine, and I was interested in the clinical part, Max House in Newfoundland was doing the education part, virtually the same time. But his PhD students went in and actually recorded how often did the physician actually touch the patient? How often did they look in their ear canal? The kind of things you couldn't do in a typical telemedicine thing. And we found out that surprisingly, you'd ask physicians, I always touch the patient, whatever, 50% of the time, except, well, we were doing this in Toronto, so the nurse had taken the blood pressure usually. 50% of the time, they never touched the patient. So we decided that, okay, we could, for these people, probably do a telemedicine thing. Then we set up a link between Sunnybrook and Flemington Health Centre in Toronto. And we had patients in Flemington Health Centre who were just regular patients in the clinic who volunteered, as well as seeing their own doctor, would in fact have a consultation with a doctor from Sunnybrook right after, sometimes before. And over the, we had what was called a slow scan system, a video system. We used actually the same technologies NASA was using, same suppliers, NASA. And then we compared what did the doctor who saw them face to face have to say, what lab tests did they do, what was their diagnosis with what the doctor in Sunnybrook who looked after them remotely. Now, on the Flemington end, there was a research nurse with the patient who could manipulate the camera, could take blood pressure, and could do something. And we showed him virtually no difference. 95% of patients, it made no difference. So then we did set up a system in Sioux Lookout, where we went into the northern Aboriginal communities where there were in fact no doctors and nurses only. We in fact went into some communities that didn't have nurses, and the system linked them into Sioux Lookout, and we looked at the effect of the system, and we were able to show very conclusively that it saved money because there were less patients transferred out of the community. But probably the biggest effect, which no one pays any attention to, is the nurses felt more secure. And the average time the nurses stayed in the communities went up by 30%. Because they just felt, and I talked to the nurses, they said, knowing I can have someone run to a tree with their skidoo, and I do a skull x-ray, I know a radiologist in sick kids in Toronto will look at my skull x-rays for me. I sleep better at night. And so we thought our biggest effect was just making the nurses feel more comfortable. The problem was, I think I said that too often, and the funding people didn't want it. It was relatively expensive, not that expensive. They didn't like funding projects that made people feel better without understanding the implications of having a nurse stay in a community for 30% longer was a significant difference in the health care they got. But they didn't quite understand that. So when we had research funding from PSI, and when their funding ran out, we couldn't get anyone. Well, Sioux County Hospital, Sunnybrook, funded the system for probably another 6 months, and we couldn't get any agency, anyone to pick up the funding. We even tried to work out a way to have it be part of the OHIP scheme, and we couldn't sell that, so it died, and regrettably. But we had fun. We had fun, and we were able to show, and we also did, most of the telemedicine systems today do education programs only, don't do clinical work. Max House in Newfoundland started with education and then moved into the clinical. We started with the clinical, moved into the education. We were able to show the educational component of it was also quite effective. And say nowadays there are telemedicine systems all over North America, whatever. But we were the first telemedicine program. The first one was out of the Boston airport, Logan Airport in Boston, where they had people who came in with skin rashes and whatever, and the dermatologist would screen them before they went through immigration. But we were the first general medical care thing. There was another system with the flying doctors in Australia, which was very similar to ours, but we'd started just before they did. There was a system in the Dade County prison system in Florida, which also looked at some of the clinical things. I'm not aware of any clinical telemedicine systems nowadays. I'm sure there are some, but I'm not sure why. Probably because we were also able to show that telephone was virtually as good as having a video. Patients could describe, someone else could describe what they were having. You have a nurse, they can listen to the chest, they can do various things. So telephone is still used all over Africa, the North, whatever. But the formal telemedicine systems aren't. We had great fun.
Well, you talked a bit about trying to make the funders understand the benefit, and they weren't interested in pursuing it any further. That's part and parcel of what has happened in recent years in the research and family medicine.
When I started, early 1970s, there was zero funding for family physicians to do research. There were family physicians in isolated places from Newfoundland all the way through Vancouver who were doing some research. But if a family physician applied to any of the federal or provincial funding agencies, you get laughed at. They were just thrown out. Family physicians didn't do research, and family physicians couldn't do research. I was fortunate to, we applied to PSI in Ontario, and we went in with a 4-phase project, and we had outlined all 4 phases in our telemedicine. They funded our telemedicine. Our phase 1, which was with the PhD students, we did with no money. And then they funded us for, I think it was $10,000 for phase 2. And then our phase 3 was, I think it was 90,000. Our phase 4 was 2 million or something. But we had progressed through that right at the beginning. We told them, these is what our plans in the future are. In fact, when they funded us up for phase 3, the executive director of BSI said, we are funding you with one condition. We have first chance to fund you for phase 4, which they funded us for, which we thought was great. And so they gave us the money. That was one of the things. And other people in other parts of Canada, family physicians, were finding little bits of money in places. People started writing papers. People started doing presentations, which began to convince people in the more traditional government funding agencies that, yes, maybe family physicians can do things and do funny things. One of my good colleagues I worked with in Sunnybrook, John Hilditch, was one of the first people to get a MRC research funding. And we used to call him the Muffin Man. He was funded by MRC to have a baker make muffins with estrogen in them to treat women with menopause. It was the first, I think, family physician to get MRC money to make muffins. And so, but that was a change that took place in the big funding agencies, that MRC could see the validity of making muffins to feed to women with menopausal symptoms, because they don't like taking pills, they didn't like taking the patch, and just baking their own. He had his recipe for how to make the muffins and whatever. And so, but people had to have got funding from other places, which was outside of the traditional government sources, so that you could put in your CV, I have got, like once I had got $1 million+ from PSI, then I could put in my CV under, research funding. I've had over $1 million in research funding. Then someone in the big traditional funding agencies would say, hey, this guy must know something about what he's doing. If someone will give him $1 million, maybe we should at least read the proposal. In the 70s, they didn't even read the proposals. They'd look at them, family physician. They wouldn't even look at them. So that was the big change. And one of the big, if you want, battles we had was it was very, very difficult. You could get drug company funding because the drug company wanted us to do their phase 3 trials, very occasionally phase 4 trials, but phase 3 trials. And you get lots of money from that, but it gave you no credibility. And they did their design, and you basically produced the patients and collected the data for them. And again, my friend John Hilditch was one of the early people who did trials funded by drug companies, who insisted in the contract. He collected the data, he analyzed the data, he owned the data. The drug company did not. And but that gave you no credibility as to getting research funding.
We've had much more success recently. We heard at Research Day about the new initiatives to fund community-based primary health care research and so on. What do we have to do to keep that momentum up, to keep funders believing in what we do?
Oh, I think funders are very smart. And you can go in with good ideas and so forth. But if you need at least someone in the project that has a track record. And if you're going to continue to get funding, you have to create your own track record, which means these people, as well as getting funding for their research, have to take the time and effort to write it up, to get it published, and so forth, to go in and say, I got $500,000 from whoever to do a project is great. But if someone, whenever I review grants, and I've reviewed a lot of them, the first thing I look at is their CV. Have they ever published anything about that? Now, if the grant was 2 years ago, you don't expect publication. But if they got a grant 10 years ago, and they got $500,000, and they still have 0 publications in that area, that $500,000 is down the drain. Now, they may have presented NAPCRAG, they may have disseminated a bit. So, in fact, now this conference has had several people talking about it, is now the grantors want you to talk about information transfer. When you get your results, what are your plans to do this? And if you don't do the information transfer, you're not going to maintain the funding. So I think both so that the general public, if you want, the family physicians gets the benefit of the research, or the health professionals get the benefit of the research, you have to disseminate. But also, if you want to maintain your funding record, you're going to have to disseminate. That's the hardest part to do research, as far as I'm concerned. I was always very good. I loved doing the research. I could do the first draft of a paper. That was fun, doing the outline and filling the thing. When it came to the stage of having to edit that, make it sound good, make it look good so the editors would accept it, oh, that was deadly dull and boring and hard work. But you could do it. Now, some departments like U of T at one stage, in fact, hired a librarian editor, and you could take your papers to her. But she basically was a language English editor, made sure that your nouns and verbs were the right form. Still couldn't do the content of it. And that's hard work. And many, many people fall down in that area. To maintain your funding in the family physician community, you're going to have to generate a database, a literature that is done by those family physicians. If you don't, funding agencies are going back. Why should we fund them? They're going to have no information transfer.
Personal qualities. What would you say to a young family doctor who's considering taking up the research discipline?
Oh, honesty. You just have to be very self-critical of and criticize before anyone else does it. Criticize your own results as you get results. Do they make sense? If they don't make sense, then is it because you've found something new and interesting? Is it because your methodology is wrong? Whatever. So I think honesty and self-criticism are the most important things. I think the other thing, because it worked in my career in several areas, is you start with an idea of the big picture, but you start small. You do something. I don't know about funding agencies now. I haven't been involved with them for 10 years. But in my day, if you had done something in your area with no money, just on your own time, on your own initiative, but you could go in with a little bit of results. One table saying, I've shown this and that in my practice, and yeah, it's my practice, but I'd like to show it in 10 clinics in Toronto or whatever. They were much more impressed. You had a method, you had a way of looking at it. So I guess the other thing I would suggest, and I reviewed for some colleagues a couple of years ago, a proposal where they were going after, I think it was $2.3 million. And they had several consultants who, from my point of view, had got a phone call while we're doing this research. Will you be a consultant? Yes, I'd love to. And I'd never seen the proposal, whatever. And I mean, it was quite obvious the way it was written that the people who wanted the $2.3 million were good people, bright and smart, and had never, ever done anything in the area. They weren't going to get any money. Again, the funders aren't naive. They've been through it, and they know all the tricks of the trade, the way you cover up and so forth. So my other suggestion is you have a good, brilliant idea. Start small. Take a little piece of it. Test it out, which gives you an idea. If it involves patients, which it normally will, is it going to be acceptable to the patients? And so people have kept time about how long it takes patients to answer surveys and so forth. And I've been involved with surveys that have 5 questions, and 80–90% of the people have not finished. And I've been involved with surveys that have taken an hour, and 80–90% of people have completed it. If it's interesting, it's made interesting, you explain properly what you're doing. So from my point of view, it makes a little bit of difference, but the length of the questionnaire is not as relevant as, do the people have time to do it? Is it well thought out? Have you explained to them properly why you're doing it? So if you do a long questionnaire, you're going to ask some questions people don't like. Sexual questions, what is their income, etc. And so you have to learn how to write those questions. Like, you never ask people how much did you and your family earn last year. You give them categories, check off, less than 30,000, 30 to 50,000. People have no problem checking off a box that says $100,000 to $120,000 a year, but you ask them and they will not tell you how much they earn. What's the difference? But they earn a lot of money. So my advice is be honest with yourself, be very self-critical, and the second one is to start small and let it grow. Other people have thought they could piggyback on someone else's big research project and then go off on their own and do their own. I haven't found, me personally, that's been worked. And I know very few other people who have done things that way and where it's really worked.
Is there anything I haven't asked?
Oh, I could talk about research for the next 6 months, but it's fun. It's going to be fun. Yeah.
Thank you so much.
You're welcome.
So nice to be here.